Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Cutaneous Lymphoma International Consortium, CLIC, Study of Outcome in Advanced Stages of Mycosis Fungoides and Sezary Syndrome, Effect of Specific Prognostic Markers on Survival and Development of a Prognostic Model by Julia J. Scarisbrick et al. My name is Lauren Pinter-Brown, and I am a health science professor of medicine at the University of California, Los Angeles, in Los Angeles, California. My oncologic specialty is in mature lymphoproliferative disorders with a focus on skin and T-cell lymphomas. The cutaneous T-cell lymphomas are a heterogeneous group of mature T-cell lymphomas presenting primarily in skin. Mycosis fungoides, an epidermatrophic cutaneous T-cell lymphoma, and Sezary syndrome, an erythrodermic variant with leukemic involvement, represent the most common types of cutaneous T-cell lymphoma. An AJCC staging system for these specific disorders, revised in 2007, describes the disease severity by its presentation in skin, T, lymph nodes, N, viscera, M, and blood, B, at diagnosis. This TNMB staging delineates patients with early stage disease, stage 1A to 2A, and advanced stage, 2B to 4B. 20 to 30% of patients has advanced stage disease at diagnosis, characterized by the presence of skin tumors, erythroderma, nodal effacement by tumor, or significant blood involvement. Visceral disease is uncommon. This distinction between early and advanced stage disease separates two groups of patients: those with early stage disease who will have a good prognosis, with a survival in some cases that is the same as age-matched controls, and those with advanced disease with a 5-year overall survival ranging from 18 to 41% in a study validating the staging schema in 2010. Worse than the 5-year overall survival we expect for diffuse large B-cell lymphoma, and without a plateau in the survival curve. In addition to staging, many groups have identified other potential prognostic markers in mycosis fungoides and Sezary syndrome. In a literature review, Scarisbrick and her collaborators identified 10 such candidate markers: stage, age, gender, cutaneous histologic features of follicular tropism, CD30 positivity, proliferation index, and large cell transformation, white blood cell and lymphocyte count, serum LDH, and identical T-cell clone in blood and skin. Large cell transformation in skin biopsies has been defined as 25% or more clusters of cells having a diameter greater than 4 times a normal lymphocyte. Retrospective but consecutive data on these variables from 1,275 advanced mycosis fungoides and Sezary syndrome patients at diagnosis from 2007 on was collected from 29 international specialist centers, the Cutaneous Lymphoma International Consortium, and subjected to survival analysis. Data completeness ranged from 99.2% for gender and age to 36.9% for other variables. The study confirms the poor overall survival of this group of patients with mycosis fungoides and Sezary syndrome, with a 5-year overall survival of 52% for the entire group. The data could not fully validate the revised AJCC staging system, as using patients with stage 2B tumors as a comparator, there was no significant difference in survival between stage 2B and stage 3. Survival for stage 4 was significantly worse, however. Interestingly, comparing overall survival across continents and U.S. versus non-U.S., there was no significant difference in survival according to stage, although treatment practices vary widely in different geographic areas. In a univariate analysis, stage 4, age greater than 60 years, absent follicular tropism, large cell transformation in skin, elevated white blood cells, and elevated LDH were identified as adverse prognostic factors. Age was also significant as a continuous variable. Of note, large cell transformation in skin was identified in a majority of patients with tumor stage disease. Of the 10 variables tested, 4, stage 4, age greater than 60, large cell transformation of the skin, and elevated LDH were independent prognostic markers for a worse survival. Combining these 4 factors in a prognostic index model identified 3 risk groups across stages with significantly different 5-year survival. Low risk, 0 to 1 variable, 68%, intermediate risk with 2 variables, 44%, and high risk, 3 to 4 variables, 28%. In the clinic, treatment of patients with Mycosis Fungoides or Sezary syndromes is individualized, and consideration of prognostic factors often play a role in treatment selection. Use of the prognostic index model identified in the CLIC study, if it is prospectively validated, may enable clinicians who treat these patients to identify patients who, if conventional treatment is failing, the patient may benefit from earlier access to novel therapies via clinical trials or more aggressive but potentially morbid therapies such as allogeneic stem cell transplantation. Clearly, the study has confirmed the poor outcome of all patients with advanced Mycosis Fungoides and Sezary syndrome, once again underscoring this population who is in need of novel treatments. When developing such clinical trials for this patient population, it will be important going forward, if the CLIC Prognostic Index, or CLIPI, is validated, to stratify such trial participants by CLIPI score, or perhaps determine eligibility for trial based on such a score depending on the inherent toxicities or the nature of therapeutic intervention. Going forward, such prospective validation of the CLIPI will be necessary and will hopefully include evaluation of additional variables such as large cell transformation that is extracutaneous at diagnosis. Clear definitions of the scoring of variables such as CD30 positivity, proliferation rate, the presence of follicular tropism and large cell transformation, with central pathology review of specimens with standard collection will be important. Mandatory collection of all variables will also be important. Collection of treatment data may also provide information about how clinicians select treatment and if these treatments are efficacious in subgroups of patients. Benton et al. At a single institution had previously proposed a separate prognostic index for the majority of patients diagnosed with Mycosis Fungoides who have early-stage disease. Ultimately, the international collaboration of specialist centers, which has been successful in this retrospective evaluation of data, if successful in a prospective evaluation, may accept the challenge of identifying those patients with early-stage disease that are destined to do less well and perhaps can benefit from more aggressive or novel therapies earlier in their course. The success of this international collaboration in completing this retrospective analysis is encouraging. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.